Ito will take the position of resection. Please, Gabon.
Thank you. And most of you are thinking, what is guys doing here again? He's nuts, presenting endoscopic salvage, and now we're going to blow the world of doing total laparoscopy, total gastrectomy. But the reason is that sleeve gastrectomy is very, very complex matters in terms of leaks. And now this is accepted as a primary procedure. We are knowing better what happens with those leaks. And again, I just remember what I just said. This is a turmoil, and they behave different from the bypass in terms of leaks. And refreshing what I just did is the perfect storm with the his angle itself, the physiological obstruction of pedorus, the his angle, axis, negative pressure, no remnants to block it. And the conventional therapy don't work. Stents works when it's early. Don't work that much when it's late after 30 days. And what I have to disclose is to get there and to heal. Sometimes it's not a very one-on-one path. Sometimes it's very difficult to get on that. Because the sleeve leaks, most of them become chronic. And the clinical management, as you see, most of the presenters telling us, usually fails. Advanced endoscopic treatment can work in most of patients, but still can fail. So what to do? How to approach that? It's very interesting that if we get back to the more simple rules, we're going to find out that the bypass is a drainage operation. So it drains itself, the food will pass, the food flow will pass through. And the sleeve gastrectomy is a closed environment, high-pressure one. So they behave very different in terms of that. And the literature provides us with some options. You can convert your sleeve on a bypass, and then you're going to have the fistula of the sleeve converted on a fistula of bypass. And most of them will heal. Or you can do, and Dr. Balthazar was the first one, I think, to provide us with both directions. One is that one that is total gastrectomy, and in this series of todinosulich, total gastrectomy were done for his angle fistula. Or the other paper that was shown here, that you can use a patch of a bowl and put on the fistula to drain it as a gastric jejunal anastomosis. And both of these options, they are really very hard to get on that. And also I have to state that most of those patients, 12 of those patients, were operated before we developed the pneumatic dilation by endoscopy. So we can conduct just with 3 after this endoscopic approach, but we must show you that is an option to do that, and we really thank the Congress to give us the opportunity to present. So look at this specific series. You have here a mean of 12 months of suffering with fistula. We don't see that in bypass very often. Reoperations in a mean of 3 reoperations by each patient. And endoscopic sections, 6 endoscopic sections by each patient in a mean, and done with people that we're supposed to know how to do endoscopy on those cases. Fibrin meshes and prostheses have failed on those patients. So we have offered for those patients, and this is a subset of the first 10 patients, and you can see here the number of previous surgeries, the number of endoscopic attempts of those patients. And this is to show you the surgery in a very brief video and how we find those patients. And also acknowledging and disclosing that to do that, you must have one of the best surgeons in town, as we have the lucky to be Dr. Ramos, and very lucky to see here on the podium 3 of the people that can handle that, but very few can. And you can see here, 1 year of leak, still have pus, still have an abscess. And the dissection is very laborious. And I will show in a moment why those leaks don't heal. They are inverted. All of them you can see here, they are inverted. You see the mucosa exposed on that. So here we are dissecting the esophagus by the liver side, trying to give an access by here. Very easy. So look at this esophagus. They are only like that when we revise. They are thick. They are inflamed. They are hard to dissect. So here we are taking the left gastric artery and vein. It is not very easy. Here you can see the fistula is open in the esophagus. So we dissect the esophagus as much as we can. We go in here, is the duodenum and pancreatic. We dissect it from below to have as more duodenum as we can have. This is the pyloric artery that we're going to take down. And here we are transecting the duodenum. This is the easy part of the operation. And now is the esophagus. You can see here the esophagus is very thick. 145 sometimes is not enough. And this will freak out a lot of people. After you do that, take care of your esophagus or say bye-bye to him to go in the direction of the thorax. But you can recover that. And look at the stomach. How beaten up this stomach are. They are very, very bad. And due to infection, even the bowel, you have to take down a lot of adhesions. And how we take care of this? We do an esophagus jejunostomy with a linear stapler. And then, once you do that, it's just to do a bypass on the way it should be. Test it with methylene glue. And then you have your bypass done. So our results are 5.5 hours operative time. A lot of patience and skills to do that. 7 days at the hospital. We have to convert 1 patient to open surgery. We have 1 intestinal obstruction at day 5 due to adhesions, and 1 pneumonia with no mortality. And we are lucky enough on this series to have no leaks. So in conclusion, the leaks after sleeve gastrectomy can be treated by total gastrectomy as an exception procedure, and if you have the proper environment to treat that. So thank you very much.
Thank you very much. Very nice series of presentation. We now move to the final paper, total opposite view from our Congress President Rudy Weiner.